Hello, I'm Celeste DeMarco. This is submission paper number 29, and I'm going to present you our project, ARFA. Let me share my screen. Perfect. So, ARFA means Argentinian Public Health Research on Data Science and Artificial Intelligence for Epidemic Prevention. ARFA is a research consortium led by CIACT, which is a research center where I work, and is also composed, this consortium, by the Secretariat of Planning and Policies of the Ministry of Science and Technology, and from the Ministry of Health is involved the National Directorate of Information System that belongs to the Secretariat of Access to Health. Actually, ARFA is a unique experience in Argentina, so let me tell you the story about how all this started. It was promoted by the authorities of the Ministry of Science and Technology, who saw the IDRC calls for proposals almost 1 year ago and thought it was a great opportunity to promote the use of artificial intelligence and data science in the public sector. So they called us, CIACT, to design the project. When we contacted the Ministry of Health, they were very interested in participating, as they wanted to start incorporating data-driven technologies, such as artificial intelligence. Then we all discussed what solution the incorporation of artificial intelligence and the use of data science could bring to the Ministry of Health. The authorities, finally, the Ministry of Health, proposed the objective of preventing future epidemics using electronic health records. And that is how this project was born. What are our objectives? Well, in fact, this is a research and development project, which has multiple objectives. Its main goal is to develop technological tools based on artificial intelligence and data science that, applied to electronic health records, allow to anticipate and detect potential epidemic outbreaks. Of course, it's too soon to know if we're going to achieve this objective, but at least we know that we are going to lay the foundations to incorporate AI in electronic health records. Why we are doing this? Because we want to assist preventive evidence-based public health decision-making with an intersectional gender perspective. As we will see, we propose an approach based on diversity and inclusion, and we are going to talk more about that later. And the last objective is to develop a scale-up strategy of the electronic health record with these expanded functionalities. All this experience will generate a series of lessons learned and recommendations that will be reflected in this strategy, a scale-up strategy. What are our 5 pillars? Well, we have summarized our project in these pillars for you to know or to have an overview of the project. First of all, they require institutional coordination that allows diverse actors to work together, such as national and provincial ministries, universities, research institutes, health institutions, and software development cooperatives, among others. Then we have the development of the artificial intelligence and data science tools, which involves the work of dozens of people throughout the country. Then we have the implementation of a pilot program of the electronic health record that is being designed by the Ministry of Health. Another relevant pillar that we are going to see in a minute is our approach towards diversity and inclusion. And last but not least, all the transversal activities, such as monitoring, evaluation, dissemination, and experience documentation. Well, we designed our project taking these points into consideration, obviously promoting interdisciplinarity, since it is the only way to work in this type of project. Scalability. We are promoting working plans for the development of the technological tools, thinking in the replicability and scalability of the experience. Adaptation is key to working with the public sector, and especially with the Ministry of Health in the middle of a pandemic. About ethics and privacy and security, well, working with health data, which is sensitive data, has forced us to design work methodologies that guarantee an ethical and safe treatment of the data. diversity and inclusion, because we select and promote the participation of women in leadership positions. In addition, we have promoted the participation of universities and research centers from various provinces of the country. This is particularly important, given that in Argentina, these type of projects tend to occur mainly in the city of Buenos Aires or surrounding areas and are merely made up with men. So our intersectional approach in our project design, we think that diversity and inclusion starts with the team. Here are some important facts that we want to share with you. As I said before, we promote the participation of women in decision-making positions. In fact, the whole team has more women than men. They represent almost 60%. Geographically diverse teams, taking advantage of the impulse given to teleworking with the pandemic, we work with members from 13 institutions distributed in 6 provinces. We also have an, of course, interdisciplinary team. We work with people from different fields: anthropology, economics, health sciences, computer sciences, biostatistics, communications, among many others. And finally, we also have members at different educational stages, from underground students to senior researchers. We really think in this way we promote better and different instances of learning. Well, surely you want to know what methodology we developed to treat sensitive data. Well, first of all, the Ministry of Health led the interinstitutional agreements to obtain the data from 2 different electronic health records that were implemented several years ago in 2 Argentine provinces. Then the data was anonymized before leaving the state headquarters and is stored and processed in the high-performance computer centers, which is located in Argentina under strict security and access regulations. Actually, only the minimum amount of data necessary to achieve the specific objective was transferred outside the state jurisdiction, and no queries or operations are carried out outside secure servers. In addition, all the people who manipulate data had to present the certification of good clinical research practice issued by the National Institute of Drug Abuse. In collaboration, this certification with the Center of Clinical Trial from the US. Then the people involved with data also signed an individual confidentiality commitment that is added to existing clauses in their contracts. And, well, of course, we presented our project to a committee, ethics committee, and it was approved. And we had our approval. Well, at the beginning of the project, we had to discover what could be obtained using data science and artificial intelligence in electronic health records for epidemiological surveillance. We did our research and 3 rows open: predictive models, computable phenotypes, and dashboards. On predictive models, a research group was selected because they have already developed a nation-based predictive model. They were asked to adapt the Asian-based model to the use of electronic health record data. To achieve this, different open data sources were incorporated into the model, which would allow changing some inputs or factors for short predictions and decision-making. For example, what would happen if schools are open and the model seeks to predict the number of cases or the number of intensive care beds in use, 15 days in advance. There are quite good preliminary results, although replicating the model requires a very important adaptation effort to a local context. Well, regarding computable phenotypes, do you remember that I told you that we promote the participation of women? Well, when? Here we have an example. This project team is made up 100% of women. Their objective is the construction of computable phenotypes from the treatment of regular expression for the automatic detection of pathologies. They work with structured data and free text using natural language processing techniques. At a first stage, they work with the construction of COVID-19 cases with very good results. A second stage will work with syndromes and symptoms for the construction of other possible phenotypes. Finally, a dashboard is being designed for decision-making regarding the spread of COVID-19 cases. It is focused on the meso-sanitarian, sanitarian meso-management. This is health actors at the provincial level in general. Could be also, for example, jurisdiction, a big city. Well, I told you about predictive models, computable phenotypes, and dashboard for meso management. In fact, these three projects are linked, since computable phenotypes can offer one more input to predict model, as well as the dashboard can visualize in the future the results of the first two lines. However, two issues that are transversal to the project, this is bias detection and ethics, are the issues that are teaching us the most, and are those that could potentially have the most impact on policy. Regarding bias, we'll be auditing AI predictive models to ensure fairness and account for potential gender, age, or geographical biases. Then, of course, we will define bias mitigation strategies in case we found them during the audit process. But we have worked a lot to make improvements in order to design a gender-inclusive electronic health record. We did a research, we contacted a lot of people, and we wrote a document with preliminary results and recommendation, which is most important, and presented to the Directorate of Gender and Diversity of the Ministry of Health. We know that this document will stimulate dialogue and debate among many decision makers. Finally, a new line of research were open on the ethical treatment of the data. This is a research on data governance that explores how data is managed and how to improve the regulatory framework to really get value out of data. Well, as you notice, this project is very big and complex. The pilot electronic health record implementation is yet another relevant activity. Let me tell you a little about the background of this. Only 20% of medical records in Argentina are digitalized, mostly in geographically advantaged areas or big cities. That is why it's so important that the Ministry of Health can implement a national electronic health record that can promote this digital inclusion as soon as possible. That is the reason why in our project we are improving and developing the electronic health record scaling strategy. This will make it easier for more jurisdictions or provinces to adopt this electronic health record in the future. And of course, if more provinces adopted the national electronic health record and the predictive tools are finally integrated to it, it would be easier to prevent epidemics outbreaks in the future. So, this pilot implementation aims to improve the electronic health record designed by the Ministry of Health, which is in a beta version, and provide recommendations to develop this scale-up strategy. So, ARFA supports the deployment of the electronic health record in a couple of healthcare centers. Several trainings were done. First, to the IT personnel to deploy the tool. But most important is that administrative and healthcare personnel were trained to use controlled vocabulary. In fact, we saw a lack of awareness of what a controlled vocabulary is, and the proper use of controlled vocabulary was key to the success of the adoption of the electronic health record by health personnel. What else have we learned so far? We were able to specify the requirements and problems that arise with equipment, connectivity and security of the institutions. Also, several improvements were requested based on user experience. So, several improvements were requested based on user experience, and more flexibility was required, so the electronic health record must allow local adaptation. That was a big learning. Well, challenges. Obviously, this road has not been rosy. First of all, we must consider that we are working with the Ministry of Health, whose priority is in the management of the pandemic. Then, of course, there is always a tension between research and management, research teams and management, or research teams' objective with policymaker objectives. Of course, we have different interests and different times to achieve goals. So, setting a common language was difficult because of these words and because we work with interdisciplinary teams, so setting a common language was a challenge. We also have to face some unpredictable travel because we have to face changes in the political authorities of the Ministry of Health. This has generated some delays in critical decisions for a while, but which also lead to the fact that as the project progresses, more areas and people were involved by the ministry. To face these issues, permanent adaptation was a challenge, but it has enriched the project a lot due to the incorporation of new views, experience, and knowledge from different parts of the Ministry of Health. Well, finally, in order to exemplify and evaluate the impact so far, we have used a contribution from IDRC that has allowed us to put into words the experience of this last month. You can see it below. Regarding expanding policy capacities, well, we have support policymakers to develop innovative ideas. For instance, this project is a good example of it. We also think we have improved the knowledge or data on many actors. For example, regarding our work done in gender, or we also did a healthcare diagnosis by analyzing the electronic health record data of one province. This is quality information for decision making. We are also generating an impact on research teams and policymakers. In this field, we improve capacity to communicate ideas from policymakers to research teams and vice versa. This is a constant learning that has allowed us to establish new forms of communication and bring two distant worlds closer together. Finally, regarding the research teams, we are very happy to see how new capacities for research are being achieved. But more important is that this project allows researchers being more aware of the policymaker needs, how they think, and how we can work together to achieve mutual goals that have impact in society. Regarding broadening policy horizons, we are very pleased that our contribution and experience about gender inclusion and responsible use of data will stimulate dialogue and debate among decision makers. This also applies with all the activities and results achieved by the pilot implementation of the electronic health record. Well, obviously it's too soon to say that our work will be affecting policies. In fact, our work regarding policy ends with a document with recommendations. Then it's all up to the policymakers, and of course, there's the Argentine context. But there are several initiatives that are on the right track and could potentially generate impacts in the near future. For example, we propose improvements towards the gender inclusiveness of the electronic health record, and we present our contribution to the Gender and Diversity Directorate of the Ministry. This directorate has a more global vision, and its work can have an impact on the entire health information system. Obviously, this is a complex issue that depends on many actors, including the participation of other ministries involved and government agencies. On the other hand, our work with the electronic health record will probably lead the Ministry of Health towards a redesigning of this policy with a scale-up strategy. And last but not the least, we are very excited about our contribution or future contributions regarding ethics and responsible use of data. The Ministry of Science and Technology, in fact, is designing a new artificial intelligence strategy, and this project will contribute with this experience from a practical, real-life example. Well, finally, in conclusion, having a day point of view since our ARFA proposal to our funders has greatly facilitated the execution of ARFA and is yielding a rich set of results that would not be possible without a transversal, inclusive approach from the start. Then from our experience, we can see that adaptability and flexibility is key to be able to carry out this type of collaborative projects that have a potential impact in policies. Also, data, safety, and privacy are key to all intersections involved in the project. For example, ethical treatment, data treatment, storage, and the analysis in local servers. But we also notice that there is a long way to go to favor regulatory frameworks that support this type of project. Then there are so many expectations in different areas of the government about the incorporation of artificial intelligence and data science for decision-making. In this regards, we make an effort to document the limitation of the developed tools in the same way that we promote the methodological design that allows the reproducibility, replicability, and scalability of them. About thinking outside the box, we realized that it's better to pay more attention to the processes than to their results. It is from the processes, with their difficulties and failures, where actual learning happens. And the learnings generate real impact through the virtual cycles of improvement iteratively. Well, finally, sustainability. We are finishing our first year, and we are starting to look for additional funding so ARFA can continue its contributions to data-driven policymaking beyond its first 2 years of funding. We know there is a lot to do regarding the AI and data science public sector agenda, and we truly believe that this great and complex experience could bring several lessons learned from research groups and policymakers in order to improve future policies. Thank you a lot, and we'll see you on Data for Policy.